Dr. Prashanti Reddy, founder and medical director, Mother Hospital, a visionary healthcare leader, Dr. Prashanti Reddy has played a pivotal role in building patient-centric healthcare services through clinical excellence, compassionate care, and strong medical leadership. So I would like to request Dr. Prashanti Reddy to kindly come up to the stage.
Good morning, everyone. A very warm good morning to the distinguished faculty, organizing committee, and all the esteemed doctors present here. I am truly honored and deeply grateful to the Pride of Healthcare Summit for this wonderful platform. I am Dr. Prashanti Reddy, Senior Infertility Expert at Obstetrician. Today I will be presenting a case on the cesarean scar ectopic pregnancy, which is an obstetric emergency, a life-threatening outcome and a challenging in our practice. Cesarean scar ectopic pregnancy. There is a rise in the cesarean scar ectopic pregnancies. It's in 1 in 531 post-cesarean pregnancies we see here, as the global rise in cesarean sections is increasing about 45% according to WHO 2023. Most of them are missed until it's too late, which may lead to the catastrophic hemorrhage, uterine rupture, and loss of fertility. So first we'll see what is the definition of cesarean scar ectopic pregnancy. It's nothing but an ectopic pregnancy in which the gestational sac implants within the fibromuscular tissue of the previous cesarean scar, where there is no myometrium or thin myometrium or less than 5 mm of the myometrium. And what are the causes and risk factor? It is nothing but a previous cesarean delivery, and the risk increases with the more of cesarean sections, the more we prone for the previous scar ectopic. And it's the most important thing is the short inter-pregnancy interval, which is very much lacking in our obstetric practice, because most of them, more than 50% of the people in the rural areas and mandal levels, they'll come to us conceiving prior 1 year of the previous cesarean section. And there are multiple prior LSES. The risk increases with each cesarean section and prior uterine surgeries like myomectomies and dilatation and curettage. And what is the differential diagnosis? What should we rule out first before coming to the diagnosis of cesarean ectopic pregnancy? It's the cervical pregnancy or low implantation of the intrauterine pregnancy or spontaneous miscarriage in progress. Most of them will miss with this. And how come is the diagnosis? It is nothing but the transvaginal sonography is the gold standard method. We can diagnose in between the 6 to 8 weeks of gestational age. What we see in the transvaginal sonography, it's the empty uterine cavity, empty endocervical canal, and we cannot see a sac in the uterus, but we see a sac at the scar site with thin or very no myometrium. On Doppler flow, we see the high peritrophablastic Doppler flow. How could we manage it? Management is like medical and surgical. Medical is a methotrexate or KCl injection, and surgically we go with, it's like ultrasound guided suction evacuation, hysteroscopic excision, laparoscopic excision. We go by a vaginal route, or we go by a uterine artery embolization assisted surgeries, and scar repair by transvaginal suturing. We have to decide, it depends on the case process. So what we have a protocol at our mother hospitals. Before going into that, we come to the case, what we have managed in our hospital. She's a 30-year-old female with a BMI of 20.2. It is a very interesting case. She is a gravida 3, para 1, live 1 and abortion 1. She has a child of last childbirth was 17 months. Before that 17 months of prior cesarean section, she had 2 conceptions in that. Already the cesarean section was a preterm. It was done at 34 weeks because of antepartum hemorrhage, and she delivered a healthy female child. After that section, after 1 year, exactly after 11 months of the first cesarean section, she had a spontaneous conception. She had an anomalous baby. She had undergone an MTP elsewhere. After that, medical termination of pregnancy, she had a profuse hemorrhage, and she has to undergo a dilatation and curettage, which is unavoidable. And after that dilatation and curettage, after 16 weeks of the dilatation and curettage, again she conceived spontaneously and came to our hospital with a pain abdomen and bleeding PV. First, we suspected it to be ectopic pregnancy. Later on, we confirmed it to be a scar ectopic by transvaginal sonography. The patient asked us, what could be the reason why this has come to me? The reason is obvious. There is no interpregnancy interval. The intervals are less than 6 months after the second termination, and there is a history of dilatation and curettage. There is a history of prior cesarean section. So many things that has led to the scar ectopic, which was unavoidable for this patient. So we counseled her everything. A video, I don't think it will be played here. So what we did was, we have done an ultrasound guided check curettage for her, but after that she had a profuse hemorrhage vaginally. So that is the scar site. We approached her through laparoscopy. That was the scar site. The scar was totally dehisced. That is the lower end, and that was the upper end. We have inflated a Foley's bulb into it so that we could see the scars, both upper and lower edges of the uterine cavity. We have sutured it through laparoscopically, and the hemostasis was secured. Fortunately, we could save the uterus of the patient. We have counseled everything until hysterectomy of the patient, but we could save the uterus, we could preserve the integrity of the uterus, and we could preserve the reproductive potential of the patient. That was the scar site, which was totally diced. Totally it was open. If we could not have diagnosed it earlier, there could have been a catastrophic hemorrhage and the patient would have been gone into the shock. It was a timely intervention and timely diagnosis, and we could do it through the laparoscopic approach. We have approximated the upper uterine segment and lower uterine segment through the laparoscopy only, and the Foley's bulb was removed at the latter end. The patient went home very happily, and we have transfusions of 2 packed cells. That was all there, but we could save the uterus of the patient. This was the video. That was the scar was totally digested. Fortunately, we could save the uterus also. The bladder was not injured. Everything was in toto. But there was a quite blood loss was there, but we could do it through transfusions. We couldn't take the video totally as it was an obstetric emergency. Just we could do this video this much only. We sutured it and it was all done. And what are the complications we could have expected in this? There could be a ruptured uterus, heavy bleeding followed by hypovolemic shock, which would lead to the disseminated intravascular coagulation, DICs, cardiac arrest, and all the risk of blood transfusions. What are the surgical complications? Yes, you have a bladder injuries, bowel injuries, peritonitis, everything, what all not. So how was the outcome? The outcome was that beta HCG was normalized by the day 28. There was no surgical mortality. Uterus was structurally intact. Menstrual cycle was resumed and future conception was counseled. How the future conception could be to this patient? We advised her the prior preconception MRI of the uterus so that to see the scar thickness. If it's only more than 5 mm inch, you should go for the next pregnancy. If it is less than 1 millimeter means, then you have again the chance of scar ectopic also. We have counseled for the preconception MRI of the uterus. So timely diagnosis of caesarean scar ectopic pregnancy not only saves the uterus, but it preserves the future motherhood. And as an obstetricians, we are not there for to deliver, but we have to be responsible for every subsequent pregnancies and subsequent scars. And we have to be, as an obstetricians and gynecologists, our responsibility does not end at the delivery. It extends to every subsequent pregnancy, every scar we leave behind. Raise your index of suspicion, invest in transvaginal surveillance, intervene before catastrophe. Thank you.
The second award goes to India's most trusted IVF Specialist of the Year 2026. Award goes to Dr. E. Prashanti Reddy, Founder and Medical Director, Mother Hospitals. May I kindly request Dr. E. Prashanti Reddy to please come forward and receive this prestigious recognition for her outstanding excellence in fertility and IVF care and remarkable contribution to reproductive medicine.
Hello ma'am, good morning. This is Yogita. Very warm welcome to Inside Excellence Award. Ma'am, can you tell us about your journey and your work and your success also?
I am Dr. Prashanti Reddy, Mother Hospitals and IVF Center and Prashanti Hospital, Chowtuppal. I have been in practice since 20 years. I have in the obstetric practice and recently into the IVF specialty. I have seen so many challenges, so many ups and downs, so many success stories and so many miracles in my journey. And for my success, there is persistence, passion towards your profession, persistence, resilience and continuous education also leads to your success. For youngsters also, you need to be very passionate and you need to be dedication to your profession, and the resilience and patience to your patients is the keyword for your success.
Thank you so much ma'am. Nice to speaking with you. Thank you.